I'm going to talk to you about bundled versus unbundled procedures. And you've heard a lot of great discussion this afternoon from our ultrasound experts. Some of the world's leaders, actually, in ultrasonography are sitting at this table behind me to my right. But are we able to reconcile what we do with reimbursements from third-party payers, including government payers, as well as private insurers, as well as commercial insurers, as well as workmen's compensation? I have no disclosures, and our basic objectives today are to talk about several procedures, 8 in general. And I want you to take home 2 important concepts from this discussion this afternoon. When you hear the term bundled, remember B is bad, bundled is bad, unbundled is good. But things have changed dramatically. 10 years or so ago, you would do a procedure, an interventional pain management procedure, epidural steroid injections, stellate ganglion block, trigger point injections, and you would separately code for image guidance, whether it was ultrasound or the use of fluoroscopy. You get paid for it. And so what happened in the last 10 years or so? Well, the insurance companies got tired of paying for image-guided procedures. And what they basically did was they started to push back. So in the last 4, 5, 6 years, they said, well, wait a minute, you have to justify why you needed image guidance for these procedures, and you could raise an appeal, and in many cases you'd be successful. Not any longer. Now there are very carefully defined and described CPT codes. So for the past 9 or 10 years or so, the tactic's been to redefine and reassign CPT codes with language that includes words like with ultrasound guidance, with imaging, or without the use of ultrasonography. And that's very important. You need to know when you're offering your patient an intervention whether or not you're going to be reimbursed for that procedure. So take a look at this. Unbundled is good. Remember that. Bundled is bad. And recently, common reimbursements for unbundled procedures, which is good, meaning you can bill separately for the procedure as well as for image guidance, include things like intercostal blocks, stellate ganglion blocks, lumbar sympathetic blocks, and that's good. Also notice from this graphic that the fee that you will get as a clinician, your professional fee, is higher if you do these procedures in the office setting than in a facility like a hospital. So you will get reimbursed at a higher rate doing this, for example, in a surgical center. Very important to understand when you see or when you utilize image guidance, you have to understand 76942 is the code for ultrasonography, and 77002 is the code for fluoroscopy. Make a note of that. Very, very important for you if you're managing your own billing. It's very important to have people who are very competent in billing if you hope to be reimbursed for your talents. Bundled, B is bad. When you see this language, it's very, very bad. And so some of the more common procedures that we do, you don't have a choice. The expectation is you're going to use ultrasound or fluoroscopy. In fact, it's almost demanded of you that you use some form of imaging, SI joint injections, lumbar epidurals, cervical, thoracic epidurals, transforaminal injections, facet joint injections. You can't opt out of that. You can't separately bill Medicare or third-party payers and expect to be reimbursed for those practices. So, where ultrasound is included in an example for the procedure, that's not good. That's bundled. So you see, for example, arthrocentesis, small joints, intermediate joints, large joints. Whether or not you use ultrasound or do a blind technique for these procedures, you're not going to be paid anything extra. Bundled is bad. Facet joint nerves, neurolytic radiofrequency, or chemical neurolysis of the facet joint or medial branch blocks. Again, this is something which you can't opt out. You cannot separately bill for over the last several years. This is a bundled code. However, look at the office-based fee compared to the facility fee. These are Medicare rates from my home state. Yours may vary here in New Jersey, New York, but by and large, they're pretty similar. You'll see that doing these procedures in the office is more lucrative than doing these procedures in a hospital setting. Let's talk about 8 common pain procedures and determine whether they are bundled or unbundled. So let's go through it from basically top of the head to the bottom of the head. Unbundled, of course, you get paid for the imaging and the procedure. That's a good thing. Unbundled is good, bundled is bad. So look here, stellate ganglion block is unbundled. I put a little positive sign there, a little plus sign there. That's good. Intercostal nerve blocks are unbundled. The rest of them are dependent on the insurer, but by and large, they favor the use of fluoroscopy over the use of ultrasonography, and that's very important to keep in mind. So where you see plus minus, for example, glenohumeral, acromioclavicular joint injections, you may get paid for imaging if you use fluoroscopy. It doesn't mean fluoroscopy is superior to ultrasound guidance, but you will get paid for it if you use fluoroscopy. You will not get paid extra if you use ultrasonography. Same for hip injections, knee injections. and other types of injections as well. And then the neuraxial injections, caudal epidurals, SI joint injections, interlaminar, transforaminal injections, you will not get paid. Those are bundled procedures. You will not derive an extra fee for using imaging. So let's talk about stellate ganglion block. Is it bundled or unbundled? Unbundled, that's good. You can bill separately. And that's the code right there, 64510, injection of an anesthetic agent at the stellate ganglion. It's an unbundled procedure. And the benefits of using ultrasonography are intuitive and inferential, right? You can see structures. You can see the thyroid gland, sternocleidomastoid muscle, esophagus, longus coli muscle, and the trachea. You cannot see any of those structures, possible exception the trachea and the transverse process, when you use fluoroscopy. So you might say, and you might argue effectively, well, I can see all these things. I can avoid intravascular injection. I can avoid intraneural injection when I use ultrasonography. SG stands for stellate ganglion, sitting on top, external to the longus coli muscle. There's your carotid artery, internal jugular vein. It's a good thing to see. Visualization is important. Doesn't anybody want to pay for that? Well, not necessarily. And the direction of your needle, of course, is from lateral towards medial, avoiding some of the great vessels and some of the other neurological structures like the brachial plexus. And again, you can use fluoroscopy for this purpose as well. Here's one of my patients seeing a nice spread on the outer surface of the longus coli muscle. The lateral view shows a tight adherence of that contrast to the ventrolateral surfaces of your vertebral bodies from C6 to about C4. Now, using ultrasound is not infallible. There are many case reports of serious catastrophic complications when ultrasound has been employed. This is a nice case report that came from the VA Medical Center at Medical College of Wisconsin in Milwaukee from Hariharan Shankar. He's a very, very popular and very active in ASRA and other societies. And so they had a 41-year-old individual with CRPS of the upper extremity. He had multiple stellate ganglion blocks done using ultrasound guidance, and on one of these, he developed a brachial plexopathy as well as an intravascular injection. So ultrasound use is not infallible. What we find from this work from Michelle Cortolo and her associates, however, is that with ultrasound, there is peer-reviewed evidence that demonstrates that you can visualize non-targeted structures like the esophagus, like the vertebral artery, and we can qualify and quantify how often that occurs, but that does not translate to safety, regrettably. So the insurance companies have not favored the use of ultrasound versus the use of fluoroscopy. Nevertheless, it's an unbundled procedure, meaning you can get paid for both any imaging that you use to enhance your injections. What about AC joint and glenohumeral joint injections? Are they bundled or unbundled? Well, it depends, doesn't it? So read this very carefully. It says arthrocentesis, injection, aspiration of a small joint, intermediate joint, or a large joint without ultrasound guidance. So they will pay you to use fluoroscopy. It doesn't mean fluoroscopy is superior to the use of ultrasound, but it's unbundled for fluoroscopy. It's bundled for ultrasound usage. So what are the benefits of using ultrasound for doing your joint injections? Well, here for the AC joint, you can see the fibrocartilaginous disc in the center. You can actually put a needle directly through the fibrocartilaginous disc and have a very successful AC joint injection. You can also have a successful AC joint injection using fluoroscopy. You can see the needle advancing towards it and a very nice linear spread of your contrast between the acromion and the clavicle in the AC joint. Ultrasound-guided glenohumeral joint. Is glenohumeral joint injection bundled or unbundled? Well, once again, it depends. If you use fluoroscopy, you'll get paid a little bit extra for doing that. You will not get paid extra for using ultrasound guidance, and you need to know this if you want to be successful in your clinical practice. So here's what you see when you're using ultrasound guidance. You see your infraspinatus muscle, you see your spinoglenoid notch, and you see the direction of your needle right over there towards the spinoglenoid notch. So ultrasound offers some coherent advantages perhaps to the use of fluoroscopy. Is there any literature which supports the use of fluoroscopy versus ultrasound? Well, basically, yes and no. Here's a nice systematic review and a meta-analysis published a few years ago. 42 studies, 406 total patients. They compared fluoroscopy versus ultrasound. The success of fluoroscopy was a little bit less than ultrasound in terms of driving the needle into the joint, into the glenohumeral joint, but this was not statistically significant, so it didn't really matter. How about intercostal nerve injections, bundled or unbundled? Unbundled, so you will get paid. You guys got it all right, the three of you in the back right there. I saw that. That was very good. Intercostal nerve injections, unbundled procedure, very good. And this is the code 64421, injection of an anesthetic agent, intercostal nerves, multiple regional blocks, etc. What are the advantages of using ultrasound versus fluoroscopy? Remember, you're going to get paid for imaging regardless of whether you select ultrasound or fluoroscopy. Well, you can see structures. You can see the intercostal artery. Remember the configuration at the inferior medial aspect of the rib. You've got the VAN, vein, artery, nerve. So if you can find the artery, you can presume the location of the nerve. You can also potentially stay out of the pleura and stay out of the lung. That's one of the major advantages. And you can see the pleural space right there, comet tails, rib, intercostal muscles, and the large vascular structures in the center of the screen, the vein, the artery, and presumably the nerve. And is there any literature which suggests that ultrasound is superior to the use of fluoroscopy for intercostal nerve blocks? Mike Gofeld, who's very prominent in this society and many others of the SIPs, published a very nice cadaveric study. There were 7 cadavers. They did 12 intercostal nerve blocks on the first cadaver, 6 on each side. They used palpation techniques, so they didn't use fluoro. They used palpation techniques versus ultrasound guidance. And they found 5 out of 6 on one side were ultrasound, and they injected latex dye, and then they dissected the cadaver. They found that ultrasound was successful virtually all the time versus only in 2 out of 6 when landmarks were utilized. When they went back to 6 additional cadavers and injected 74 total nerves, so basically 6 on each side for these 6 cadavers, they found that ultrasound was highly successful. But does this translate to clinical success? Well, there's no study to prove that. What about hip intra-articular injections, bundled or unbundled? Again, it depends on which modality you select. You will get paid extra for the use of fluoroscopy, but not for the use of ultrasound guidance. And this is, the language is very clear here. You must familiarize yourself with this if you're in private practice. If you're at the university or the large medical center, they'll do the billing for you. It says very clearly, without ultrasound guidance. Fluoroscopy reimbursed, yes. Ultrasound guidance reimbursed, no. And so this is the benefit of using ultrasound. However, you can see targets, you can see structures, you can see the acetabulum, the femoral neck, the femoral joint space. This is what it looks like under fluoroscopy. Again, you will get paid for this hip injection using fluoroscopy, but you will not be getting anything extra if you use ultrasound guidance. Is there any data to substantiate the benefit of ultrasound versus fluoroscopy? Here's a journal that I'm sure we all subscribe to. It's on all your kitchen tables, right? The Revista Brasileira de Reumatologia. The effectiveness of image-guided intra-articular injection, fluoroscopy versus ultrasound, prospective randomized blinded study. Joint flexion was better with fluoroscopy, but the VAS reduction was somewhat better with ultrasound. In summary, it was a wash whether you selected the use of ultrasound or fluoroscopy for these articular injections. What about knee injections, bundled or unbundled? Once again, it depends on whether you select the use of fluoroscopy versus use of ultrasound. Again, read the language very clearly, ladies and gentlemen. This is what you have to adhere to. Let's say you're the world's greatest ultrasonographer and you're very resistant to fluoroscopy. You don't want to expose yourself and your ovaries and your testes to extra ionizing radiation. Of course, don't use digital subtraction angiography. That's subject of another talk. But you can see here that it says without ultrasound guidance. This language is very clear and distinct. This comes directly from Medicare. They will give you something extra for fluoro, but not for the use of ultrasound. You can use ultrasound, however, for diagnostic purposes, but not for the injection phase. And there's some great benefits to the use of ultrasound for these knee injections. You can see your major muscular targets as well as your ligamentous structures. There's your vastus lateralis, intermedius, medialis, rectus femoris. You can see your medial meniscus, MCL, LCL there. And this is what it looks like using fluoroscopic imaging. Again, you stick the needle in, you inject some contrast. You try to stay outside of the anterior cruciate ligament, which is why I approach the joint a little bit laterally to get posterior to the ACL, because I don't want to cause ACL rupture. Then you inject your medication. Is there any evidence to suggest the superiority of one modality over the other? Not really. This was a comparison of the use of ultrasound, very high success rate of getting into the joint knee space compared to, again, a blind technique like our orthopedic colleagues are prone to using. When do you see orthopedic surgeons putting ultrasound probes over shoulders, knees, hips, or ankles? They don't do it. They palpate, they feel, they jab a needle in, and they just inject wildly. Well, guess what? They miss anywhere from 50 to 70% of the time when they do that, and this study actually validates that. What about the genicular nerves? You saw Dr. George Chang Chen give us a superior discussion about that. If you use fluoroscopy, if you use ultrasound, this study, which was published recently in the Journal of Pain Physicians, showed essentially the same results in terms of success rates, efficacy, complications, side effects, and so forth, regardless of whether you selected the use of ultrasound versus fluoroscopy. It's unbundled for fluoroscopy. It's bundled for ultrasound use. Now, where does ultrasound have some utility? Because by now it's all been Debbie Downer. I've been up here telling you that you're not going to get paid at all when you use ultrasound. That's not true. Trigger point injections, yes, regardless of whether you choose fluoroscopy or ultrasound. And you can see a single tendon sheet, carpal tunnel syndrome, which George pointed out as well. What about filling up your implantable drug delivery system, your pump? Yes, you will get paid a little bit extra if you use ultrasound, but not necessarily, in fact, not with the use of fluoroscopy. Bundled is bad. B is bad, okay? So all the neuraxial procedures that we do each and every day for all of our patients, you're not going to be reimbursed at a higher rate whether you select the use of ultrasound guidance or the use of fluoroscopy. You're going to get a flat rate for that, and it's going to be determined by the type of insurance the patient has, not by your selection of an imaging modality. So interlaminar injections, cervical, thoracic, lumbar, transforaminal injections, cervical, thoracic, lumbar, SI joint injections, facet joint injections, and so on and so forth. You get a single fixed price. But is there a basis or foundation or rationale for why you might want to select the use of ultrasound guidance? Let's look at caudal injections. Here's what it looks like fluoroscopically. You see the sacral hiatus where we find the sacrococcygeal ligament. You place a needle in there, maybe one of Gabor Wax's famous catheters in there, direct it to the right, direct it to the left. You lyse the adhesions and so forth, and you get a beautiful epidurogram. And this is what you see when you use ultrasound guidance. You can see some of the same structures. Now you can see the sacrococcygeal ligament. You can see the sacral cornua, the caudal canal, and the floor of the caudal canal. And here you see a needle placed in a sagittal longitudinal in plane view using ultrasound guidance for your caudal injection. This is another view using fluoroscopy. Does it make a difference in terms of outcomes? Actually, no. Several studies came out from South Korea over the past several years. The first was 2013. Then the same authors went back in 2015 and looked at new data. The first study was prospective, randomized, and blinded. These are the studies of Dr. Park. You see that there are 3 Parks here. This was Park, Park, and Park. 120 patients. There was no difference in whether or not you use ultrasound guidance or the use of fluoroscopy. In terms of pain, or in terms of the Oswestry Disability Index, patients got better regardless of imaging technique. Remember, this is a bundled procedure. The same authors went back and looked at 110 patients. This was a retrospective look. I actually read the article very carefully. These are not the same patients that they studied in 2013. Again, reduction in pain by 50% or more, improvement in the Oswestry Disability Index of greater than 40%. No difference regardless of whether or not you use ultrasound guidance versus the use of fluoroscopy. A more recent study, just more recently published, again, caudal epidural steroid injections for failed back surgery syndrome using ultrasound versus fluoroscopy, no difference in outcome. So that's the take-home message. You can have patients get better. You have to be an expert at what you do, but are you going to get paid for that expertise? That's what you have to ask yourself. Sacroiliac joint injections, bundled or unbundled? Bundled. You're not going to get paid whether or not you use imaging of the ultrasound variety versus fluoroscopy. Does it make a difference clinically? That's what you have to ask yourself. And here's the language in the CPT codes. With image guidance, the expectation is that you're going to use fluoroscopy and or ultrasound guidance. Again, you can use both. You heard Miles Day very politically correctly say he uses both for each and every technique. So image guidance is built in to the reimbursement for this technique. Is there an advantage to your SI joint injections using ultrasound guidance? This is what you see. You see the sacrum, the ilium, needle track. This is what you see using fluoroscopic imaging. You see a nice joint gram if you get lucky enough to put it directly in the posterior aspect through the ligament there. And studies would again show that the success rates are pretty much equivalent. Here's a study which actually shows more favorable attainment of spread of contrast using fluoroscopic imaging compared to ultrasound imaging in terms of actually gaining access to the inner portion of the SI joint. It doesn't matter. What matters is that you're not going to be paid for your SI joint injection with imaging. You're not going to get that imaging fee because this is a bundled procedure. Controversial topics, and I'll finish up in the last minute and a half or so. Lumbar facet blocks, cervical medial branch blocks, cervical facet joint blocks. How many folks are using ultrasound for these techniques? Almost everybody at this. Andrea said no. That's right. Okay, there you go. So that's exactly right. So not only, again, this is a bundled procedure. It doesn't matter which modality you select, ultrasound versus fluoroscopy. You're not going to get anything extra for doing so. And is there any language in that? Of course, it says with imaging guidance. Actually, the language in Medicare is very interesting. It says fluoroscopy or CT scan guidance. It doesn't even use the term ultrasound. So you may struggle if you're submitting a claim to Medicare for ultrasound-guided facet joint injections of the lumbar or cervical spine. The data shows, again, lower lumbar spine, ultrasound versus fluoroscopy, no difference in efficacy, no difference in side effects, no difference in complications. Here's ultrasound guidance versus fluoroscopy for cervical spine, medial branch injections. VAS, no difference. Disability index, no difference. Success rate, no difference. Basically a wash across the board for cervical facet joint mediated pain, whether you selected the use of ultrasound guidance or fluoroscopy to manage these injections for your patients. What about going higher up now, C2, C3 at the transverse process? Does this frighten anybody to do injections this high up using ultrasound guidance, ultrasound imaging? I'll show you what it looks like over here. Again, there was no difference between groups whether or not fluoroscopy was utilized for these cervicogenic headache patients or whether the use of ultrasound was guided. Here you can see the way the ultrasound is placed very high at the nuchal crest by the inion, right below the inion, below the occipital nerves, and you'll see your vertebral lamina, spinous process, and spinal cord. Is anybody not concerned about this? Does this scare anybody at all in the audience? It doesn't scare me, not really. I'll show you what scares me. This scares me. I'm scared by this recurring thought every evening when I lay down alone in my bed. And I think that I adhere to what Dr. Bhuvanandran and Dr. Rathmel said a few years ago, published in the journal Anesthesiology. When you undertake cervical injections using ultrasound guidance, you've got to really be very careful, because even though you think you can see certain structures, never forget, ultrasound, like fluoroscopy, is a two-dimensional representation of three-dimensional human anatomy. So never take for granted that you can see the entire tip of your needle. Never take for granted that you know exactly where that needle, the end point of that needle is in reference to large anatomical structures. Final two slides here. Remember that bundled injections, bundled is bad, unbundled is good. Remember that you need to know the codes for ultrasound as well as fluoroscopic imaging. Remember that you will get paid somewhat more for doing these procedures in an office setting compared to a hospital type of location or a facility type of location. Always better to do these in your office in terms of remuneration. Ultrasound's proven to be safe for some, but not all interventional pain procedures. I think cervical spine is one of those areas where it's a little dicey. Bundled procedures becoming more common. I anticipate in the next 10 years, everything is going to be bundled. There will be no unbundled procedures. Mark my words, by 2031, that's going to be coming down the pike. And you must specify fluoro use if the code states that ultrasound is not reimbursed. You must include that in the language that you submit to your third-party payer. You need a great coding specialist to help you with this. Don't tread water alone. Go out and learn these codes. Take this PowerPoint with you if you're starting a practice. Take this to your billing and coding specialist if you have an established practice, and go through all of these things with a fine-tooth comb. The data, of course, this is always a disclaimer, right? Data is still accruing. That's when we don't know what else to say, and we've been speaking too long already. Thank you for your time and attention to this matter.